All right, well, welcome today to our webinar that we're going to be doing on 340B best practices, just some tips and techniques for things to keep an eye out for and look on within your 340B program. And this is brought to you today by Optimal 340B. And let me just tell you a little bit about myself. I have a background working both in medical and financial industries for the majority of my life. I have been involved directly in the 340B since early 2015. Initially, I worked with a full service consultancy for covered entity programs. And we did everything from registration to implementations and all the way through terminations and successful HRSA audits. In that time with that prior company, I did develop multiple in-depth reporting and training tools, excuse me, for covered entities and contract pharmacies alike that can show every side of your 340B program. And one of the things I specialized in was qualifications and changes in qualifications and full through financial reviews. So I have worked with, in that time, with a large number of 340B software companies or TPAs to customize and optimize well-covered entity programs using an extensive knowledge of the 340B program, detailed reviews of the TPA settings, which of course includes the knowledge of those settings and what they mean, what they do, pharmacy dispensation records, and patient medical records. I have regularly found as much as a 30% increase for covered entity program benefits. All right, so some of the things we're going to touch on today, we're going to touch on these 5 most important parts of things you want to check on your 340B program. First off is going to be provider panel. Referrals, then patient medical records, your contract pharmacies, and your third-party administrator. So for your provider panel, many of you already probably know the provider panel is the most overlooked and easiest item to check and maintain in any 340B program. Without an accurate and complete provider panel, you are going to face multiple missed opportunities, a very high risk for 340B drug diversion, and it really just does become an overall headache in your 340B program. So having your provider panel correct and maintained within your 340B TPA portal at least once monthly is very important to just have a great foundation for your overall 340B. You know, again, I just mentioned that you want to do it at least once monthly, but ideally, if you can integrate your software or have someone that can come in and make those changes as providers leave or come on with you, that would be spectacular. That's, of course, in a perfect world. Another thing here that is a pretty common missed opportunity is that a lot of covered entities don't have a complete panel. And there's multiple reasons that this happens. Some of it's just not knowing what providers can and cannot be included on a panel. Some of it is because TPA was at one time they couldn't do certain things with providers that weren't exclusive, or the settings in the program just never were updated. You know, there's a lot of different reasons that they're not complete, but just you want to double check that you do have a complete panel and include any prescribers. So it's not just doctors, any prescribers that meet your HRSA definition of eligible, which the actual definition is a healthcare professional who is either employed by the covered entity or provides healthcare under contractual or other arrangements, as an example, referral for consultation, such that the responsibility for the care provided remains with the covered entity. So in layman's terms, this just basically means if you have a provider or prescriber, I call them, that is employed or contracted to perform services for your patients, then you can include them in a panel. These can include staffing agencies, like a lot of EDs use staffing agencies and have a rotating list of people that can come in and out. Medical assistants, part-time providers, even if they moonlight elsewhere, 340B or not, they can all be considered as eligible for 340B. And a contract, just so everyone knows, can be as simple as, this provider is going to perform services for our patients on our behalf, and both of you sign it. There just needs to be something in writing that says they're performing services, the patient is still yours. So some of the providers that do not count are going to be ones that, the big one is if they're just renting space in your facility and they're still maintaining their own patient records and, they just have, let's say, a private practice or a private office right there. So that is one that would not be considered as eligible as they are not your covered entity patients. All right, referrals. Referrals, when they are handled properly, can be absolutely huge. Obviously, this is going to depend on how your facility is structured, how your community is structured, and what all different services you guys can provide or contract out to provide. The biggest thing is the referrals are valid only when the referring provider from your entity is a 340B eligible provider and they're working in a 340B eligible location, and your patient medical records must include that you are maintaining overall care for that patient. So typically what that means is that you have notations in the patient record that say, we are referring John Smith out to such and such oncologist. And then once that visit happens with the oncologist, you get records back saying oncologist diagnosed with, leukemia, and patient care will be as follows. So then you are still maintaining care for that patient, and you have to have those referrals for it to be something that is HRSA compliant in a audit. This can be difficult, obviously, in a normal day-to-day facility, depending on how you are managing this, but it certainly can be done. Now, there are also some limitations in regard to what third-party administrators within 340B can and cannot do with these referrals. Most TPAs can handle referrals and looking at those qualifications and being able to do things around that, but knowing how they do that and how they're actually performing the qualifications without those providers on your panel is huge in, again, maintaining compliance. All right, so patient medical records, we all use them every day long. A surprising number of covered entities, though, do not have them integrated with their 340B software. So some of the benefits are you can increase capture by including those providers who are not exclusive or don't only work for you, and you can compliantly include those. And these patient medical records, particularly ICD-10, are essential for capturing those referral prescriptions or tying any prescriptions from your providers to a particular visit. Some of the most common things that come up as far as errors in patient medical records are that there's incorrectly mapped data points between your EMR system and your TPA system. A lot of those are the location of the visit, the provider NPI or DEA, patient names is a really, really big one that's kind of highlighted below, and diagnosis codes. You know, most everybody's switched over to ICD-10, but there are still a lot of systems that are, even TPA systems, that are only set up for ICD-9, or they're only getting sent ICD-9 and they need ICD-10. Most 340B admin companies will not reach out to you and tell you that there is a problem with any of these mapping points. So you kind of have to know in a lot of cases what to look for and how to look for it to see these misses. And that kind of brings me to the name mismatching, because this is the #1 issue. Even with everything correctly mapped, the #1 issue is going to be your names. So names that are hyphenated, they're shortened from something else, so Dave versus David, suffixes, things of that nature, are all sections, or all pieces, excuse me, of the 340B world that get disconnected between the TPA software and the data that's coming in from the pharmacies. All right, so your EHR or EMR data should be delivered to your TPA weekly at the very minimum, but preferably every single night. And those updates or those deliveries do need to include any edits, changes, or addition to your patient files that have been made since the last file was sent. So a lot of times these are going to be diagnosis codes that are going to be coming in. You know, I know that billing can take anywhere from, billing and coding can take, you know, 24 hours to 4 weeks, sometimes more, depending on how everything's set up. So you really want to make sure that all of those things are included, all of the updates. And this goes through, in best case, this goes through the actual EMR company. Almost every EMR company out nowadays can integrate and knows how to integrate in what these 340B software vendors do want to see. And of course, there's always assistance to be able to get that integration done or check it. All right, next we're going to hit contract pharmacies. So even with recent manufacturer pushbacks and cuts within 340B, contract pharmacy relationships are still a great partnership and a great benefit to you. Within that, you do want to always regularly review contract pharmacy captures and explore things like other model options that are available. A lot of times you'll see brand only, brand winners, or winners. Brand only sometimes, or excuse me, brand winners is sometimes called a brand select, or the winners is sometimes called a hybrid model. And if you have ePrescribe, you do want to review that on an annual basis, because you want to see where your prescriptions are being sent most of the time. And if you're not already contracted with those top pharmacies, get a conversation started, because your scripts are already going there. You might as well take a look at and see what kind of benefit could be there for you. Because a lot of times, you know, as things change and as networks change, where all the scripts are going to are going to change. So you want to try to limit the leakage. And obviously, if you don't have the contract pharmacies at all and haven't recently reviewed for that potential, definitely get some research going to see what is feasible, to see what's out there for you. Because again, even with these manufacturer pushbacks and 340B cuts, contract pharmacies are still a huge area for benefit within any 340B program. So the last one seems probably obvious, but again, it's something that I see all the time. Make sure when you have a third-party administrator or that data company that's processing all your 340B stuff, make sure you know what the TPA fees are and why you're being charged for that. I have seen companies that are like, well, I don't know what this, you know, I've got 6 different items listed here on my TPA invoice, but I don't really know what this one, and this one are. So you know what? Ask, contact the billing department or the invoicing department, contact your TPA main contact or your case manager or account manager if you have one, and ask those questions. And then annually or 4 to 6 months prior to your contract renewal, check out there if there are any other TPA options that can provide the same or even better services to you for a lower price. Especially in the last about 5 years, there has been so much growth within 340B. There are a ton of TPAs that have come out or become much, much stronger parties and that have just such in-depth services and capabilities and customer service and charge significantly less than some of those older TPAs. You know, when it comes down to it, don't be afraid to change just because that's what you've always been with, or you've been with that TPA for so many years. It does not hurt to take a look at other TPAs, to have a conversation, to see demos. What do they have available? What can they do about X situation? You know, what kind of pricing do they have? Shop around. You don't even have to give notice to your prior TPA while you shop around. You know what's out there. It can really benefit you in the bottom line. And another part of third-party administrators here is the actual settings. And this is a lot of what I get into in depth, especially with Optimal 340B, is you want to review what settings that you have in place on a regular basis. You know, the preferred time to do it is going to be with your semi-annual internal audits that are required by HRSA's compliance standards. When you're doing those audits, you want to take a look at every single setting, know what it means, know how it's impacting your program, either positively or negatively. And you also want to be able to explain that. So this is just a side note on HRSA compliance. You want to know what your settings are and how they work so that you can have your 340B policies and procedures accurately reflect what's actually happening in your program, so that if HRSA comes in for an audit, you don't have to scramble and do all of this in the back end. And once you've got it set up and you're doing your checks every 6 months, the internal checks, you'll be able to see, yes, this has changed. No, this hasn't changed, and you'll have more of a checklist and a process that as you go through it will get much easier over time. And semi-obvious thing. A lot of programs, again, are missing out on claims because there hasn't been a review of these settings. And a lot of these companies are coming out with new capabilities, new tweaks here and there within current capabilities that change how the program can or cannot work, and weren't available when the initial implementation was done, or the implementation is fine, but it was chosen with a prior C-suite. So, you know, CEOs, CFOs, DOPs are all changing all the time. And so, you know, maybe it worked back then, but the pharmacy system has changed, or your guys' CFO has changed, and, you know, there has been an update and there's not the same understanding as there was. So you know what? It's time to take a look at them. See, is it still working for you, or are there other options that you have? And a fairly broad disclosure here, you know, TPA settings are confusing. Even if they have very plain language on the settings, the way that they work in the back system and the actual internals of the 340B and how they can affect those programs is very detailed. And you do have to spend a lot of time working with the TPA and figuring out just how these settings do or don't work. And, you know, this is where I kind of get into, how's Optimal 340B going to be able to help? So Optimal 340B is going to work with your facility, your TPA, and any other 340B partners you may have to understand your current program, and then we can provide you an initial savings or optimization benefit estimate. We're then going to review the entire 340B database, including any contract pharmacy dispensation records, to find those missed claims, errors that are going on, or even new 340B opportunities for you, so that we can realize and actualize that potential. We then work with any and all of your 340B vendors, like your TPA, in some cases the wholesalers. If you have other consultancies, we can work with them as well, your contract pharmacies, everyone, so that we can implement the actual solutions for you. So you get to be as hands-off as you want to be. You know, obviously no decisions will be made, no pen will be to paper until everything is understood and discussed with you. But then the little details, the day-to-day, the going to the implementations meetings and corrections meetings can all be done by Optimal 340B, so that you can actually spend that time realizing and managing your other aspects of your busy job. And of course, the end result is you guys are going to get an optimized 340B program. And then after that happens, we will continually and regularly monitor your program for any corrections or adjustments that need to be made. And we provide you guys with as in-depth reporting on the financial side and even the qualification side as you guys want. So that is something that is provided on an ongoing basis after the initial implementation. Again, Optimal 340B works with your facility to ensure that your 340B program is the best it can be. And our goal is to save you hours of time, energy, and worry, let you get back to your main bulk of your job, and maybe even spend some more time with your family, you know, and your loved ones. So we want to make this as easy on you as possible. We want to make this program as beneficial as it possibly can be for everyone involved, including your patients and community. So again, thank you so much for joining today with watching our 340B best practices. And best ways to get a hold of us here, you know, we have our main website, optimal340b.com. My direct phone number is actually 208-860-2157. And you can even text that if you need something. We will get back to you just as soon as we can, but that is my direct line. And my direct email is lissa@optimal340b.com. And just so we make sure you stay up to date with anything that Optimal 340B has available, we want you to also follow us on LinkedIn if you have an account. And you can just search Optimal 340B. You can follow us, connect with us there, or even just go straight to the website and subscribe to our blog. All right, well, I want to again say I hope you guys have a wonderful rest of your day, and thank you so much. We look forward to hearing from you soon.